Thanks very much. So I think it's becoming more and more important to get good outcome from cataract surgery, like Bruce showed with the changing and improvement in formulas. Because when I started, it was really just a question of making the patient to see better, with or without glasses did not matter. But now it's becoming more and more of a refractive procedure. So I won't go through this, but I will concentrate on the astigmatism because the formula and everything Bruce has already eloquently discussed and explained about. Why astigmatism matter? Because I'm astigmatic in one eye, and that's how I do see with that eye. It's also very common because more than 30% of our patients will have 1.5%, and more than 10% of our patients coming for cataract surgery or refractive lens exchange will have more than 2 diopter. So the first thing that you need to think is how you need to measure the astigmatism, what you need to measure. And also it's important that you know how much astigmatism are you self-inducing when you do your cataract surgery. And again, the web comes to help. You can go on the Hill website, not only for the IOL calculation formula, but also to establish in knowing your pre-op corneal and post-op corneal astigmatism, how much you induce, because this is based on your keratome, on different settings, etc., etc. And once that you know, you can use that at your advantage in the way that you correct astigmatism. And that's just to show the Hill website. You look it up, put your data in, and you will find what is your induced surgical astigmatism. Measuring astigmatism, I think there are different ways that you can measure, but the simplest way is just having a pentacam and a IOL master biometry or a different similar laser interferometry tool. For simplicity, I prefer to refer to astigmatism as 3 different types: mild, moderate, and high. So in my mind, it's clear I should treat those 3 astigmatisms. So mild is 1 or less, moderate is higher than 1, but less than 1.5, and high is more than 1.5. And we did study in the past just to show how much we can induce our astigmatism with 3.2 incision rather than 2.4. So mild astigmatism is easy. Remember your incision, always temporal because you induce less astigmatism. On axis are really good for oblique incision, and superior incision should definitely be avoided when you're dealing with against the rule astigmatism because you will make it worse. And by the way, bear in mind that whilst with the rule astigmatism is easier to correct for anatomical reasons because the corneal diameter is shorter vertically, but also because there is the lid and the limbus, which actually goes on top of the anatomical cornea. So your vertical superior incision will always be closer to the center of the cornea. So your incision will be there. And therefore, you will cause more astigmatism, which can be advantageous when you're dealing with the rule astigmatism. But if you do it with someone with against the rule, you will make it worse. So for this level of astigmatism, easy, just be careful with your incision planning, have a diagram of your cases, and that's especially important when you're using premium lenses, because they're not forgiving in terms of astigmatism. Moderate astigmatism, well, you've got several choices. You can think about corneal incisional surgery, and they all work pretty well, or toric lenses. In terms of corneal incisional surgery, if you want to have a rough idea of how big your incision needs to be, etc., you can use the Donnell film nomogram. There is one for limber relaxing incision or arcuate keratotomy, and there is another one for femtosecond laser arcuate keratotomy. So if you plug your numbers in, they will tell you the size of the incision, the position, etc., etc. And although you can base everything on rule of thumb, this is useful for planning because it's ever so easy to put the incision on the wrong axis, whilst having a nice diagram will always help you not to make mistakes. Normally, how much astigmatism can you expect to correct with incision? Well, the number is there, but remember there will always be a little bit of regression, which is worse in our older patient when you are correcting against the rule astigmatism, because through our life, with the rule will decrease, whilst against the rule will increase. So take that in your plans. So for moderate astigmatism really is based on your ability to correct it with incision. With the rule, easier. Against the rule, more difficult. So I have a tendency to go to toric IOL more often, where you're dealing with against the rule astigmatism. And also the type of surgery that you're doing. If you're using premium lenses, multifocal, then I think you're bound to use a toric, because if you don't correct it, the lens will not work, as we all know. Eye astigmatism is as simple as mild astigmatism because there is not much of a choice. You have to use toric lenses. Always measure the astigmatism twice, make sure the axis is correct and is concordant with whatever device you use. Normally we use Pentacam and IOL Master. And remember that with the new IOL Master, like Bruce explained, you do measure the total keratometry. So when you go on the Zeiss website, you can calculate your lenses with total keratometry, only with anterior keratometry, and see what the difference does it make. Surgery needs to be exacted when you use toric lenses because you really want to have a rexus that is not too large, especially with haptic lenses because they're less forgiving. Plate optic lenses are more forgiving because you can have a slightly larger rexus and they will rotate a little bit less and they won't get out of the capsular rexus. So either you perfect your capsular rexus technique or you can use the femtosecond laser if you believe in it. And this shows that, of course, like one would expect, toric lenses are much more effective than anything else in correcting the higher degree of astigmatism. This is a planning scheme, and all the calculator, this is the Zeiss, but if you go on the Alcon and others are all very straightforward because all that you need to do is input your number and then they come up with the correct lens to implant the axis. And they're ever so useful because you must have those in front of you when you do the surgery, same position at the head of the patient, marked, and then make sure that you mark the correct axis. This is just a quick video of a toric lens. Here the marking was done manually, but of course there are markerless systems now made by different company, and shows you quickly the rexus. There are different ways that you can do it. The important thing is to do it the right sides and well centered when you use a toric lens or any kind of premium lenses. And then you can just use your standard cataract technique. Because we will be talking about cataract, this is a classical stop and chop technique, and then we are inserting a plate optic lenses. Markers are there. One advantage of plate optics is that you can rotate clockwise and anti-clockwise, because with non-plate optics, if you go beyond the marking point, then you need to go once again 355 degrees all around. So, there are advantages and disadvantages. And I quite like to use bimanual because then you can use opposite hand movement and the rotation is much faster if you use monomanual IA system. Make sure you remove your viscoelastic fully and then you do the final tuning of the positioning of the lens, because otherwise remnant of viscoelastic in the bag can make the lens tilt a little bit and move. This is an example of one of the marker-less system. There is another one from Malcolm, from other company. They all work pretty well. I'm not sure if there is a huge evidence they work better than simple slit lamp marking, but probably they do, especially for the difficult eyes. One issue with toric lenses is rotational misalignment. Number one, if you mark your patient properly with markerless system or at the slit lamp, it is very, very rare. The higher risk is especially for highly myopic eyes because of the large capsular bag, but also I'm finding this more and more. If you do more surgery, you realize that it's actually more difficult to make the horizontal position of the lens to stick with what it is when you finish the surgery compared with the vertical. I'm not really sure why, but if I look at my own outcome, the correction of the astigmatism with toric lenses is almost always spot on, whilst when it is with rule, but when it is against the rule, to me appears much more difficult to correct. And this is a paper that we did at Moorfield some time ago with Oliver Findle, and the mean rotation at 6 months was really not significant, because even with a high power lens, 2 degrees of rotation is minimal. The easiest thing to do if your patient does have a residual astigmatism and is unhappy is just go on to a website called astigmatifix.com, because then what you do, based on your post-cataract surgery refraction and the position in which the lens should have been and which the lens is, you will get the best possible advice if it is worthwhile to rotate the lens or not. If it is, then I will have no hesitation, comforted by the result of the Astigmatifix website, to go back in, explaining to the patient and rotate the lens in position. But if it is not, then you have to consider other means of correcting the astigmatism, which could even be laser vision correction. That's why it's useful when you do refractive surgery and cataract surgery, having everything around you, not only access to good cataract surgery facilities, but also excimer laser and anything else that you may need. So I hope that it's clear. The take-home message is try to keep it simple. Divide your astigmatism in mild, moderate, and high. Mild and high are easy because you use incision for 1, below 1, and toric lenses for the higher, more than 1.5. In between is really your surgical choice based on your experience and on the type of lens that you want to implant. Monofocal lenses, a little bit of astigmatism can play in your favor, especially for reading if there is a bit of monovision. But multifocal lenses, I'm always caught with the patients got 0.5 astigmatism at 55 and the vision is poor. But as soon as you correct the distance vision with your astigmatism, is perfect both for distance and near. Thank you. Any question on this? Nope. So shall I just get going, Milton? So I'm not sure what I'm supposed